kind of pick up where we left off last class and continue on with the respiratory system and talking about the nasal cavity and the nose region there. In 211, you learned about the lacrimal duct system, and we talked about how when you cry, you get a runny nose, and that is partially what we're going to discuss here when we talk about the nasal lacrimal duct here. Pretty much same type of scenario when you have an increased tear secretion from the lacrimal glands. You notice that the lacrimal glands on the lateral side of the eye, and it washes across to the medial portion, and you have the medial canthus and the lateral canthus, which are these openings that lead into the nasal lacrimal duct. Point being is the nasal lacrimal duct will conduct the secretions down into the nasal cavity there. And one of the things that we have to kind of understand when we're discussing the nasal cavity is, and I mentioned this on Wednesday of last week, all right, its job, all right, is to prepare the air that you are inhaling, all right, for the more sensitive environment of your respiratory system, okay? So it needs to not only warm, clean, and it also needs to humidify the air because of the epithelium that lines parts of the respiratory system, especially as we get into the actual respiratory zone of your respiratory tract. So in this region, we're going to see that the air gets warmed up because of that large, extensive vascular network that you have in the nasal cavity. Unfortunately, because you have that large, extensive vascular network, you're more prone to nosebleeds, especially if anything happens to that epithelium that lines the nasal cavity. All right, but because we are taking things from the external environment towards our internal environment, all right, the mucosal membranes are going to help deal with any foreign debris, okay, any pathogenic or infectious material that is going to enter in. Now, because of the epithelium, when we're dealing with the ciliated pseudostratified columnar epithelium there, all right, we can then allow any material that gets caught in that mucous membrane, okay, we have our cilia that are going to beat back and forth and flush it towards the oral pharynx. All right, now, the book likes to say it gets swallowed, but to be honest with you, not everybody swallows this material. Sometimes they spit it out. But the point being is a lot of that material will be expelled out of that nasal cavity there. All right, big time for humidity. We don't really have to worry about that too much down here in South Carolina. But trust me, when you're living up in the cooler climates, one of the worst things for me when I lived up in New York was walking out of the house. Not only was it in some situations single-digit temperatures, but sometimes negative single-digit temperatures, but it dries the air out so bad, so it makes you more prone to upper respiratory tract infections because it dries out all that epithelium, and which is a huge problem. So down here we don't have to worry about it too much, but at the same time the nasal cavity will help to humidify the air. And not only that, the concha there help to swirl the air around to enhance all of these processes for the warming, the cleaning, and the humidifying there. All right, paranasal sinuses, we saw this in 210. All right, these are going to be the sinuses that are going to be closely associated with the nose. All right, but all of these sinuses drain into the nasal cavity. All right, your frontal, ethmoidal, maxillary sinuses, and even the sphenoidal sinuses, all of these, and that's why folks that get congestion, headaches, sinus infections, most of the time, if something makes its way into the nasal cavity, it can then travel from the nasal cavity to any one of these sinuses and cause an infection in those areas there. And plus, it's tough to get into those areas for treatment. So, in a situation in which you have a sinus infection, I never had a sinus infection until I moved down here. The first 2 months I got a sinus infection, and I never had one. Well, welcome to Greenville. Welcome to Greenville. But it can be depending on how bad or what type of bacteria that gets into that area. To deal with a sinus infection, it can be really problematic and troublesome. So here you can see, all right, on this picture here, all right, we got our frontal sinuses, all right, and then our maxillary sinuses. The ethmoidal and the sphenoidal sinuses are more posterior but lateral there to the eyes there. But keep in mind, the epithelium that we're dealing with in these areas are the same type of epithelium that's in the nasal cavity, pseudostratified ciliated columnar epithelium. I don't know if do you have that picture in your book? No, probably not. Okay. Basically, what this picture is showing you again is going to be, all right, the different bones that are involved in the nasal cavity. All right, here's the frontal sinus, the sphenoidal sinus. All right, we have our nasal cartilage on either side. All right, and then we have our turbinates or the concha bones here, the inferior nasal concha, middle nasal concha, superior nasal concha here. When it's covered by the mucosal membrane, then it creates those turbinate structures. And then in between, all right, these turbinate structures, we have the meatus, which is that opening there. Okay, you can see there's a couple openings here. I wouldn't worry about this one too much, but here's the opening for your nasal lacrimal duct in between the inferior nasal concha and the middle nasal concha. All right, you can see here's the floor the floor of the nasal cavity, or the maxillary bone here. Okay, and you can see up here, here's our nasal bone right up there. Okay, so enough with the nasal cavity. We're going to now move into another anatomical structure called the pharynx. And the pharynx is, like it's described here, a funnel-shaped passageway. So it basically has a relatively large opening, and it just starts to taper down. And there's three parts to the pharynx as we move from superior to inferior. And basically name it for the cavity or the region that we're closest to, meaning the upper portion of our pharynx, which is posterior here to the nasal cavity, all right, that's the nasal pharynx. Right? The nasal pharynx is designed for air transmission only. Okay, air transmission only. So that's where we're going to see, all right, that ciliated columnar epithelium there. As we get down here to the oral pharynx, which is posterior to the oral cavity, all right, and we get down to the laryngeal pharynx here, which is going to be posterior or in close approximation to your voice box or the larynx here, we're going to see a different type, and I'll talk about it in a second, a different type of epithelium. Because now, as you know, you breathe through your mouth too, but not only that, you take liquid in through your mouth and you eat, all right? So when that food has to move down to this passageway into the pharynx here, all right, food can be a mechanical stress irritant, all right? So the actual process of swallowing, especially if you swallow something that's relatively hard, all right, it can irritate the epithelium that lines the pharynx. So we're going to see a different type of epithelium. We're going to see a stratified epithelium in the oral and laryngeal pharynx here. All right, so quick reminder, nasal pharynx, all right, is going to be lined by the pseudostratified ciliated columnar epithelium, all right, air passage only, no food unless you're regurgitating food up through your nose or milk or whatever, all right, but no food, all right. Part of that allows, because of the soft palate there, the uvula and whatnot, it will elevate it up as you are swallowing liquid and food to block food from going up into your nasal cavity. Or at the same time, you've got the epiglottis, which is that flap-like structure in the back of your throat that covers the opening to your trachea. All right, that's called the glottis. So you have these mechanisms that prevent food from moving into the nasal cavity and also into the trachea, all right, and it's going down the esophagus instead of the trachea here. So that soft palate helps to block food or drink from entering into the nasal cavity. Also, we'll see here, all right, is the opening here to the middle ear or the eustachian tube. Okay, and this is, I talked about this just briefly last week. All right, that opening there, all right, in which you'll have, it helps to equalize the pressure. And that's important, all right? equalizing that pressure, especially when you're on an airplane or driving up into the mountains there. All right. If you swallow or chew gum, you're going to stimulate the movement of the tensor palatine muscle, which helps to adjust the tympanic membrane, so you have equal pressure both on the outer ear and on the in the middle ear there. All right. But what we're going to see is that tube that's just behind the tympanic membrane that drains down into the throat is a place where we get to see lots of bacteria that like to creep up here. I was telling you folks this on Wednesday about ear infections and how a source of entry into the inner ear is through this opening, the auditory tube opening there in your nasal pharynx there. Right? We saw the pharyngeal tonsils here in that area. Okay, again, tonsils are going to be secondary lymphatic tissue, and it's located on the back portion of the nasal pharynx wall, and we give it a special name when the tonsils become enlarged, all right, adenoids. All right, let's drop down here into the second part of the pharynx, the middle region here, the oral pharynx, okay? So the anatomical landmarks that we use to denote where the oral pharynx is going to be the soft palate there, the posterior 1/3 of your mouth, to the hyoid bone, which is about C4, C5, if you're going to be using the vertebral segments there to locate it. The hyoid bone is that bone that sits, all right, in front, all right, of your neck there. It has no bony attachment. It's the only bone in the body that does not articulate with another bone, okay? The oral pharynx is where we're going to have both food and liquid and air, all right, move through that area there. So that's why that area is lined with non-keratinized stratified squamous epithelium. Stratified epithelium handles mechanical stresses very well, okay? So in this area, because it's a shared region for both food and air and liquids, right? We line it with that non-keratinized stratified squamous epithelium, because when you're swallowing things, or not so much with drinking, but more so with swallowing, you're going to be scraping off the non-keratinized epithelium, the outer layers there, is food friction, all right, between the food and the tissue, all right, you're going to lose some of that, so it's best to have as many layers as possible there. We're going to see two sets of tonsils, palatine tonsils, which are going to be on the lateral portions of this cavity, and then the lingual tonsils, which are going to be laterally on either side of the tongue there. Okay? Palatine and lingual tonsils are both found in the oral pharynx. Then finally, the last portion is the laryngeal pharynx. All right, this is going to be from the hyoid bone all the way down to the opening of the esophagus here. Okay, and again, same thing. Both food, liquid, and air are going to be moving through that passageway. So again, we line it with non-keratinized stratified squamous epithelium to handle the mechanical stressors there. We're going to talk about the larynx here in a moment, but just to kind of see here, all right, when we talk about, here's the nasal pharynx, right, lined by that pseudostratified ciliated columnar epithelium, okay, because then again, only the passage of air is moving through. We get to the posterior portion of the oral cavity, that's when we get into the oral pharynx there, all right, and that's where we're going as we transition down further. Right, then we're going to move into the laryngeal pharynx where our voice box is. So we're going to talk about a couple of the structures there, okay. So that's all the upper respiratory tract, what we just talked about. Okay. Now we're going to move into the lower respiratory tract. Okay. So pretty much the lower respiratory tract is from your voice box or the larynx all the way down to the terminal bronchioles. All right. So that anatomically, structurally, that's pretty big. Okay. Pretty big. The upper respiratory tract is not going to be as big. So you've heard of terms like upper respiratory tract infection, lower respiratory tract infection. So when they're talking about a lower respiratory tract infection, right, someone that has bronchitis, that's a lower respiratory tract infection. Okay? So in the lower respiratory tract, we're going to see gas exchange. All right? And all the structures that are going to be part of the gas exchange, which includes our alveoli. All right, and then we haven't talked about the alveolar ducts, but that helps with movement of air. And then the respiratory bronchioles, which is just going to be the piping system to get air down into the alveoli. Okay, that's our goal, is gas exchange. So we have to facilitate gas exchange in the easiest way possible, all right, where we want to facilitate the diffusion of respiratory gases across a membrane. And we'll get more into that actual process when we get into the lecture portion. Okay, so let's talk about the larynx here. All right, so the larynx, or the voice box, all right, you're going to see this structure, all right, between the laryngeal pharynx, which is the posterior portion of your pharynx, and the trachea there, or I hate to say this, the windpipe. Okay, so its job, all right, is several fold here. One, we have to move air through there, okay, because it involves getting air down into the trachea, all right. Also, it's how I am communicating to you right now, all right. It's to make sounds, and hopefully they're sounds that you understand, all right. And then also, we need to keep the airway, all right, clear of any foreign materials. So the larynx helps to prevent, all right, foreign materials or harmful materials from entering into your respiratory tract. Okay, so we saw that with the epiglottis. When you swallow liquid or solid or food, it pushes the epiglottis closed, and when I say closed, it pushes it over the opening to the trachea, and therefore you don't get any foreign material down into your windpipe. And then on occasion, if that happens, usually you'll cough, all right? And that's a reflex to try to clear that airway there. All right, has anyone ever heard of the Valsalva maneuver? All right, Valsalva is a maneuver in which we increase the abdominal pressure by closing, all right, the epiglottis and contracting the abdominal muscles. And it's a good way to do several different types of orthopedic examinations. For example, if you wanted to see if somebody had what's called a space-occupying lesion, say you're suspecting a herniated disc of some sort in their back. So what you do is you ask them in the sitting position to take a deep breath, hold that breath, try to exhale that breath, but don't exhale it, and try to bear down like they're going to have a bowel movement, obviously. You don't want them to do any of those things, but at the same time, what that does is that increases that intra-abdominal pressure, and if there's a disc herniation, they'll feel a significant amount of pain. And in order to do that, again, we close the epiglottis, we contract the laryngeal muscles in that vicinity also, all right? And it is going to increase, for example, if you want to elicit that test to see if they have a space-occupying lesion. And we've all, well, actually, I shouldn't say we've all done it, because I know I'll never be experiencing childbirth, but, all right, if you've had to, unfortunately, if you're constipated or whatever, or if you have to pee really bad and it's not coming easily, you're going to enter into the Valsalva maneuver when you're trying to push things through, all right? So that's something that is quite common, especially you don't even realize it during Lamaze breathing exercises, in which they will facilitate the Valsalva maneuver. Coughing and sneezing reflexes, these things are huge. Someone told me once, and I heard it, and I don't think it's true, but again, I don't have any backup, that if you sneeze, the amount of air force that you push out of your mouth is as powerful as a hurricane. Which a class 5 hurricane is over 165 miles an hour. I seriously doubt that my lungs can generate 165 mile an hour blast. But it's a lot. Point being is when you sneeze or cough, is you're trying to clear, all right, your respiratory tract of foreign materials here. All right. If God forbid, if something is inhaled, all right, and it makes it into your lower respiratory tract, all right, it will stimulate, all right, your thoracic muscles and your abdominal muscles to contract quickly to expel the air, all right? And what we'll see is, we'll talk about the vocal cords here in a little bit, all right? It forces the vocal cords to open up, and it's basically, if you've ever used a keyboard cleaner, you know, it's a compressed air can, and you just spray things. It's the same type of concept. It helps to expel and force that air to make sure that we've cleared whatever that foreign material is that's entered into the opening there. All right, so let's get into the larynx here. All right, the laryngeal inlet there, which is basically just an opening, all right, between the pharynx, all right, and the larynx. I know a lot of this rhymes. We're going to talk about the players here first, and then we'll get into a couple of pictures here. All right. So when we're dealing with the larynx, all right, you have 9 pieces of cartilage. Some are paired, and some aren't. Okay. And so obviously, what connects a lot of these pieces together are going to be our ligaments and muscles, and we'll talk about that because you have extrinsic, all right, laryngeal muscles and intrinsic laryngeal muscles. All right, so the paired, the single, we've seen the thyroid before. The cricoid cartilage sits right below, all right, the thyroid, and then you have your epiglottis cartilages. Okay, and again, those are going to be associated with that flap-like structure, right, that helps to protect the opening of the glottis. Then we have the paired, the arytenoid and the cornulicates, all right, and the cuneiform cartilages. This should look familiar because we had the cuneiform bones there when we were talking about the bones of the foot there. All right. All right. So thyroid cartilage from last semester. This is the one that sits anterior, okay, on your throat. It's more pronounced in men, but women, you can palpate yours. All right. And they describe it as a shield. All right. A shield shape. All right. Cartilage that you can really see on the front and on the side here, okay? And it's nicknamed the Adam's apple. Just below that is the cricoid cartilage. It is a ring-shaped cartilage. And then we have our epiglottis, which is described as a spoon-shaped structure, all right? It's anchored, all right, to the thyroid cartilage here, okay? But again, its job is to close the glottis or the laryngeal inlet, all right, and prevent the entrance of any type of food or liquid, all right, especially when you're swallowing. All right, the other cartilages, the paired cartilage, are the arytenoid, the cornuculate, and the cuneiform here, okay? Now, all of these are made up of hyaline cartilage except for the epiglottis. That's made up of the elastic cartilage, which makes sense. Because once you're done swallowing, or once you're done swallowing food or liquid, all right, the epiglottis springs back open to its original shape, so you can let the flow of air back into the trachea here. All right, these other cartilage structures, all right, are hyaline cartilage. And you heard me talk about, all right, in the larynx, you are going to have, all right, ligaments and muscles. So we break down, all right, the ligaments into the external or the extrinsic, excuse me, and then the more inner ones, or the internal, the intrinsic. All right. So the extrinsic we'll see on the surface of the larynx, all right, and it's going to attach mainly to the hyoid bone, which sits superior to the thyroid gland. Now remember, the hyoid bone does not make any bony articulations, all right, with other bones in the body, okay? So it's a site for ligamentous and muscular attachment there, okay? Our intrinsic ligament, this is where we're going to get into your vocal cords, all right? We're going to talk about the vocal ligaments and the vestibular ligaments, all right, as we move in a little bit. Let me show you a quick picture here. All right, so you can see here, all right, here's the hyoid bone on the anterior view, all right? And then we've got some ligamentous tissue here attaching onto the superior portion here of the thyroid cartilage. Right below the thyroid cartilage is where we see the cricoid cartilage, okay? But our extrinsic muscles here are going to be found on the anterior and lateral surfaces, more on the outside or more superficial, all right, on top of these, on top of the bone here and the thyroid cartilage. Now, when we go to the posterior view, all right, we'll see, all right, the other cartilage here, all right, the arytenoid, the cornulicate, and then the cuneiform cartilage on the backside. I got better views for that, okay? And then we can see some of these more smaller muscles here on the inside that which are going to help with speech phonication here. All right, so let's, if you got your atlas handy, okay, you can see here, all right, this is kind of like a anterior lateral view, all right, of the larynx here. Okay, so again, it's not labeled on here, but this is the hyoid bone up here. All right, just inferior to that is going to be your thyroid cartilage. And then inferior to the thyroid cartilage is the cricoid cartilage. And then this tube-like structure here, that's the trachea. And then you'll have your tracheal cartilages that wrap around it, also known as C-rings. We call them a C-ring because they don't completely go around, all right, the whole trachea. There's actually an opening in the back. Okay, so keep that in mind. It's not a circle. It is not that. Okay, there's an opening in the posterior portion there. We'll talk about that in a moment. All right, good so far? All right, so just keep in mind the most superior cartilage is going to be the thyroid cartilage here. Okay, then you have the cricoid cartilage below it, and then we have our tracheal cartilages below that. All right, so if we pull up this view here, you can now see, all right, up here is the nasal pharynx. We start to taper down behind the oral cavity. There's the oral pharynx. All right, and in this region here is the larynx. And that's going to include, okay, now it's tough to see here, but this is a lateral view of the epiglottis. All right, that epiglottis is that flap-like structure. So when you're swallowing or drinking, the epiglottis will move down and cover, all right, the opening there, or the glottis, so food can go down behind into the esophagus here. All right, so you can't see, but there's this little slit-like structure. Okay, this arrow is partly on top of that slit-like structure, and that's called the glottis. That's just a hole. It's an opening. Okay, so when you're breathing air in, it's going to come in through here. It's going to come in down the pharynx, go into the glottis, and down into the lungs. Okay, that's where air goes. All right, food goes back here. The esophagus is behind, all right, the trachea. Behind the trachea. All right, let's zoom in on that area and get a little bit of a better view here. Okay, so again, just a couple things. Here's the larynx here, our voice box. All right, so you've got your epiglottis, that's that flap-like structure. So the air, when you're breathing in, comes in and down, just like that. Okay, so above the glottis, you have the ventricular folds, and we'll talk about what they do here in a moment. Then you have the opening, that's the glottis. All right. And then you can see here's the epiglottis above that. All right, then you can see the superior most, it's not labeled here, but this is the hyoid bone right up here. All right, then inferior to the hyoid bone, that's your thyroid cartilage. And then right below the thyroid cartilage is the cricoid cartilage. And then you've got your trachea with the C-rings here. All right, and then you have your vocal folds right below the opening here to the glottis.
So would it be considered the true vocal cord?
Oh yeah, we're getting there. Yep. All right, so now let me show you the superior view here. You get a nice view here. All right, so again, when we're looking down here, this opening here, all right, is leading us down into the trachea. So again, it's hard to see, but this is the epiglottis. This is that flap, right? And it will close down over this opening when you start to swallow food. So it'll close down over that. Okay? So now when we're looking, all right, closer here, you can see the ventricular folds are this, like, I don't know, flesh-colored material. More medial to that, okay, you have your vocal folds here. And that's when we're going to start talking about how sound and true vocal cords and then our false. And then the opening here, all right, is the glottis. That's a space in which the air is going to move down into there. All right.
I looked up the season thing, and it said it was about 10 miles per hour.
10 miles? Yeah, so that person was full of it. And they told me, there's no way I'm generating a hurricane force wind. It just doesn't happen. All right. All right. So now we're going to get into the vocal ligaments. And these are going to be those ligaments on the backside that you're going to see. All right. I'm going to come right back to this slide here. Okay. So here again, this is a superior view here. This is the front. This is the back. All right. So here's your thyroid cartilage. All right. And then here you can see the cricoid cartilage. And then down here are some of our paired cartilages, right? So you've got the cornulicate, all right, cartilage, and then the arytenoid cartilage here that kind of swivels. And you can see here there are these ligaments, okay, that are attached here onto the very end of the arytenoid cartilage. And you can see what happens, the positioning, all right? When they're closed or adducted, they're close together. When they're abducted, they're open. You can see how they kind of swivel and move around. All right, we're going to go through that here in a second. All right. All right. So when we're looking here at the vocal cords, right, or the vocal ligaments, right, when they are covered, and actually this is the picture here. This is a better view of the vocal ligaments because they're covered now with the mucosal and the soft tissue material here. Okay, so you can see, again, here's that epiglottis. We're looking straight down at it, right? You can see when they are closed or adducted together here, right? You got your vocal folds here. We'll talk about what the rim of glottis is in a moment, the opening there, okay? And then you can't see them, but underneath this tissue are going to be, all right, our different cartilages there, all right? The arytenoid is deeper down underneath here. All right, so these are the structures that actually make the sound as I am using them right now, all right, as I'm talking to you. So as the air is moving through, as I'm exhaling, okay, I'm manipulating the vocal folds here, otherwise known as the true vocal cords, these white structures right here, all right, these guys here. Let me use your, all right. Number 19B, these are the vocal folds. These are the true vocal cords, right? So as those are moving back and forth, adducting and abducting, all right, that's how I'm able to make the noises also by changing some of the laryngeal muscles in my throat here, okay? So we call those the true vocal cords, okay? And it's those structures, when we manipulate the size of that opening, that causes, as I'm exhaling, the air passing through makes the noise there. So the actual opening, not including the ligaments, is the rim of glottis. When we include the boundaries of that opening, the vocal folds there, okay, then that's when we refer to it as the glottis. All right, so you may have heard this guy, the false vocal cords. Those are the vestibular folds. Those were the structures that we saw here, okay? The vestibular folds are up higher here, okay? And so these guys here are going to be known as the false vocal cords because they don't make any noise, but they are above the true vocal cords, okay? So we refer to those as the vestibular folds there. All right, let's finish up and just talk about a few of the muscles here and then what makes noise. All right, like I told you, we have two types of muscle groups here when we're talking about the larynx. We have the extrinsic and the intrinsic, okay? So the extrinsic are going to be the more superficial, closer to the surface of your skin here. And so they're going to play a large role here, all right, with swallowing. So if any of you have ever had to go in and get a swallow test done, and what a swallow test, I mean, there's lots of different types of swallow tests, but what I'm talking about is when they go in, if they're suspecting thyroid issues, if you've ever had your doctor or nurse or whoever put their hands on your thyroid and palpate that and asked you to swallow, and then has anyone ever had a swallow test done before? They palpate? Okay, so you know what I'm talking about then. Yeah. So what they're basically doing, yes, they're just trying to see, one, if the thyroid gland is fixated or if it's moving, all right? But they're also assessing the extrinsic muscles there, all right, that are in close proximity. Sometimes when people get an infection that affects the thyroid gland, you can get fibrotic adhesions that build up there, and it can affect the actual functioning of the thyroid gland, all right? So we'll see with the extrinsic muscles, their origin is going to be on the hyoid bone or either the sternum, one of those two things. All right, and then they're going to insert onto the thyroid cartilage. Does anyone remember the difference between insertion and origin? Origin is the less movable part of a muscle, where it's the less movable attachment site for a muscle. The insertion is where you're going to see more movements. Okay, so if we're talking about the biceps brachialis, where it attaches to on my radius, that's the insertion. That's the more movable part. All right, when it's attached, it's got two heads. All right, but when it's attaching up towards my shoulder, that's the origin. All right, that's the less movable part. So that's what we're talking about here. All right, with the extrinsic. All right, the intrinsic ones. All right, these guys here are going to play a huge role in manipulating the opening, all right, of the rim of glottis. So that means these muscles are the ones that I'm using, all right, to talk to you folks, okay? And they do play also a role in swallowing, okay? So when these muscles, the intrinsic muscles, are being contracted and relaxed, they're going to manipulate the change in the opening of that rim of glottis as I am exhaling too. There's a lot of that's involved in voice phonication and how I'm producing. Obviously, there's controlled breathing involved, all right? I'm manipulating my diaphragm, some of my secondary inspiratory muscles. But we all do it without thinking. But it's those muscles that will help with the following here. These guys, all right? Sound production. There's three things that we use when we're talking about sound production. Well, one, all right, we're definitely involving the intrinsic laryngeal muscles and how they manipulate the opening to the rim of glottis. But also, as we are exhaling, all right, as we're speaking, all right, will also affect these three, all right, characteristics. When we talk about range, all right, this has to do with, all right, what sex you are, because it depends on if you're producing androgens. Okay, for males, because we produce testosterone, that's going to cause a thickening, all right, of our vocal cords, and that will give us a more deeper range. Okay, pitch, this has to do with how we manipulate, all right, the intrinsic laryngeal muscles. Okay, so if you increase or contract these muscles and increase the tension, you'll get a higher pitch. Okay, if you decrease it, all right, so pitch is based on tension, all right, range is based on, excuse me, the length, but the thickness of the vocal cords. All right, then loudness, all right, this is all dependent upon how much and how forceful, all right, the air is as it's moving across your vocal cords. Okay, so you get more air across, the louder it sounds. All right, let's talk about the trachea here for a little bit. All right, your windpipe. All right, so done with the larynx, done with the pharynx and all that. Now we're going to start to move down into the deeper portions of the respiratory system here. And we're going to talk about the main tube that brings air into your lungs before it bifurcates, before it divides, okay? Keep in mind its location. It is directly in front of the esophagus. Now, the esophagus can collapse. The trachea can't. And the reason why is it's because it's got these cartilages here, all right, these C-shaped rings made of hyaline cartilage. And they surround the opening, the trachea there, prevent it from collapsing. You don't want that to happen, all right? Whereas the esophagus, all right, can collapse. All right, it's not always patent. And just because it's collapsed doesn't mean that it's dysfunctional. It just means that we don't need to have it opened up. Now, if you are swallowing, remember I told you these tracheal cartilages, they're C-shaped, and there's an opening in the back, okay? And that opening there is a good way to ensure if you are eating food, all right, because the esophagus is back here, all right, sometimes if you're eating something big, it allows it to bulge forward a little bit. And so it gives it a little bit of room to move into the posterior portion of the trachea there. Okay? But keep in mind that these C-shaped rings are made of hyaline cartilage. All right? And hyaline cartilage does have a perichondrium. All right? And it ensures that the trachea does not collapse and that it's always patent or open. Okay? You do have a muscle in the back. This is not a muscle that you need to be able to identify, but we call it the trachealis muscle. All right, and that opening where that C-shaped ring is, that's where this muscle resides. So in this region right here. Okay? So like I was saying, it's this muscle that allows, when you are swallowing something, all right, for the esophagus to bulge forward. All right? But also, in the coughing reflex, this muscle plays a role. Speaking of the coughing reflex, that's this person. I shouldn't say persons. It does remind me of a name, Karina. There's actually a song, Karina, but it's spelled differently. But anyways, the carina is located on the interior of where the trachea bifurcates. So it's right in this region here. There's a little ridge here, okay, and it's loaded with these sensory receptors. So if you breathe in dust, or hopefully, unfortunately, if you swallowed liquid, if it went down, like the wrong pipe, something went down the wrong pipe, all right? If it flows down into the trachea, it will irritate those sensory receptors and initiate the cough or sneezing reflex here, all right? So it helps to just clear those irritants, all right, out of your respiratory system here. Now, here's the thing. It is, and you need to know this, it's on the interior. Because I'm going to tell you, well, I don't know if we'll, yeah, right here. I'll come right back. This is the part that I'm not a huge fan of, that the department has labeled VAT 21, where we see the bifurcation here of the trachea into your primary right and left bronchioles. But they have an arrow pointing to the bifurcation as the carina. The carina is on the inside, okay? But, if you see that labeled on a test, all right, just like that, all right, pointing to that spot, that is the carina. I do want to say I have, oh, here it is. You can see a better one here, all right? So here is where the carina is going to be, right there. This is an internal depiction. So you can see here's the trachea, and then it bifurcates into the left and right primary bronchus. And it's this little shelf-like structure here right there. So when stuff comes in, it'll irritate that, and it'll invoke, all right, that coughing reflex, the trachealis muscle to contract. Okay. So here you can see a nice histological slide preparation, cross-section of the trachea and the esophagus. Now look at the esophagus. See how it's kind of collapsed down? You can see here, here's the trachea in the front, here's the esophagus in the back. Okay? Esophagus is pretty much just lined with our stratified squamous epithelium, all right, and then you have smooth and skeletal muscle involved in that. But when you're not swallowing or taking anything in, it's nice and collapsed. Meanwhile, all right, this is always open for business. And so the cartilage sweeps around from the back portion to the lateral portion of the front, and then back around again. You have this opening here, and that's where the trachealis muscle is. All right, there's the carina. All right, so when we're in the actual trachea, of course, I need to talk about histology. Okay. So you have several layers here, okay? So you have 3 layers, all right? The mucosa, the submucosa, and then the adventitia. All right, so the innermost layer is known as the mucosa, all right? Again, lined with pseudostratified ciliated columnar epithelium. All right, that means it's going to have goblet cells, and it's going to be producing mucus. Epithelium always sits on a basement membrane. That's what this is showing us over here. Okay, so here's the mucus that's produced. All right, here's our pseudostratified ciliated columnar epithelium with our goblet cells. And then it sits on this little thin basement membrane. Okay? For our purposes, epithelium always sits on a basement membrane. Okay? Except, there's a couple exceptions, but for this semester, we talked about one for lymphatic capillaries. They don't have a basement membrane. All right? Okay? So then just below that, then we have our lamina propria. Okay? And so all of that, from here to here, all of this is our mucosa. Then below our mucosa, we have our submucosa. And this is going to be our connective tissue. Most epithelium always sits on connective tissue. All right, and that's where all the stuff is. We're going to have, all right, that's where we're going to have our loose connective tissue, ripe with blood vessels, ripe with more mucus glands, all right, ripe with lymphatic tissue, all the stuff that we need to have to keep our respiratory system clean and safe is going to be located here, all right, in the submucosa. And then finally, all right, you can't see it on this slide, but the outer portion, all right, the adventitia, that's going to have our elastic connective tissue. So we have a little bit of stretch and give there. And then we have our tracheal cartilage, our C rings, which wrap nicely around all that. Okay, so let's get in and talk about the bronchial tree, our conduction system here. All right, because ideally, we need to move air from the external environment in towards the internal environment of our lungs so we can have that exchange of respiratory gases. That is our goal, to get oxygen to the blood vessels in this respiratory tree and to get carbon dioxide out of the blood back into the air here, okay? So we're going to start off with the big structures and then wind up with the smaller structures, okay? So remember in 210, we talked about the primary bronchi, and then they branch off into the secondary bronchi and the tertiary bronchi. We're going to work our way down until we get to the respiratory bronchioles. And those are the smallest pipes of our respiratory system, okay? And then at the end of the respiratory bronchioles, that's where we're going to see our alveoli, those clusters of grapes. That's where we're going to see the diffusion or the exchange of gases there, okay? So the trachea splits into the left and right, all right? Primary bronchiole, okay? This is the sternal angle. Do you all know where the sternal angle is? We don't really talk about it. It's basically, remember the manubrium? Remember your breastbone made up of three structures, the manubrium, the sternal body, and then the xiphoid process? The sternal angle is where the manubrium and the sternal body meet each other. You can actually feel it. It sticks out a little bit, okay? So that is going to be, all right, where you're going, that's also where your second rib inserts onto the sternum there, okay? So this is where we're going to see, all right, where the trachea splits at that area there, okay? This is very important, especially if any of you are going to be going into like nursing or whatnot. The right bronchus is shorter, wider, more vertically oriented, which means it goes down like that, okay? So that means if you were to swallow something, it's more likely to go into the right bronchus because the left goes out more horizontally. So it's easier for stuff to slide down in there, okay? So it's going to affect the right lung more often than not than the left. Okay, so the right bronchus is shorter, wider, which is going to accommodate more, but also it's more vertically oriented, so it allows stuff to slip down in there. Okay, so each bronchus is now going to break down into our secondary bronchi, or what we call the lobar bronchi, because your lungs, and we haven't seen this, and we will when we do the gross anatomy of the lung, all right, you have your right and left lung, and then you have lobes. The lungs are subdivided into lobes, okay? So these secondary bronchi go out to these individual lobes, so we call those lobar bronchi or secondary bronchi, okay? So again, as we move further and further, all right, into the lungs, we are going to see these bronchi becoming more narrow. The diameter becomes less and less and less. Then we break up into what we call the segmental bronchi or the tertiary bronchi. Okay? The point is, this keeps getting smaller and smaller. We get to bronchioles, and then finally, we get to the terminal bronchioles. Now, this is important because this is the last part of the conducting zone. Conducting zone, we'll talk about this in lecture. Conducting zone is, you're not going to see an exchange of gases. No gas exchange occurs in the conducting zone. Okay? That only occurs in the respiratory zone. Okay? So think about it. Conducting zones, we try to conduct oxygen down into the lungs and conduct carbon dioxide out of the lungs. All right? You will not see an exchange of gases in the conducting zone. It's going to be in the respiratory zone there. Okay? So this is what we're seeing here. You can see on the picture here. Here you can see there's a nice big trachea, the big windpipe here. Then it breaks down into the left and right primary bronchus. You can see here's the left primary bronchus is more horizontal. The right is more vertical, a little bit larger. Then it breaks off into the lobar or secondary, all right, bronchioles that are going to go to the individual lobes of the lung, and then they break down smaller and smaller tertiary, then to the bronchioles and the respiratory bronchioles. We'll get into that later on. All right, you can see how it just gets smaller and smaller and smaller and smaller. Okay, so as we move through the bronchial tree, we are going to see that the hyaline cartilages are eventually going to disappear. Okay, we'll see, all right, the right and left primary bronchial will have hyaline cartilage there, but as we get down into the bronchiole, we will not have any cartilage present. All right, but here's the thing. Granted, we lose the cartilage because the job for the cartilage is to keep the airways patent so they don't collapse. So as a trade-off for losing the cartilage in our bronchioles, we start to see a thicker layer of smooth muscle. It becomes proportionally larger. Smooth muscle is important. We saw how important it was for the circulatory system because with the circulatory system, right, if we wanted to manipulate the opening to the blood vessels, all we had to do was constrict or relax the smooth muscle in there, and that would change the diameter, all right, of the blood vessels. Same, all right, type of concept works for, all right, our bronchioles. Okay, so if we are going to wanting to constrict or decrease the diameter of the lumen, then what we'll do is we'll undergo what's called bronchoconstriction. All right, and we'll see a narrowing of the lumen into the bronchioles, less air. Well, unfortunately, we see that in allergic reactions, especially for asthmatics. It's these smooth muscles that get irritated and causes bronchoconstriction, and therefore they decrease the passage of air into these structures. Well, if we want to increase the diameter of the bronchioles, all we have to do is get the muscles to relax. We call that bronchodilation. When we get bronchodilation, we can move more air, all right, into the respiratory bronchioles. Okay, so here's a great picture that kind of illustrates that. All right, so you can see, all right, here's the trachea. We start to get down here into the primary bronchioles, then they divide into the secondary, all right, the lobar, and then they'll branch again into the segmental. But as you see, we keep getting smaller and smaller, and this is the cartilage rings here. So as we start to get to the smaller ones and we get down into the bronchioles, we no longer have those cartilage rings there. All right, no problem. We have that smooth muscle there that helps to manipulate the opening, all right, or the diameter here of our air conducting system. And then once we get past the bronchioles, then we don't have any more cartilage when we get down here into the respiratory tree. All right, so here, this probably should look familiar because this was something that you saw back in Bio 210, all right, when we were talking about, here's the trachea. All right, here you can see your right and left primary bronchi. And then our primary bronchi then divide again into the secondary bronchi, right, or the lobar bronchi, and then the little color tubes here, those are the tertiary bronchi.
So 22B and 22C are split?
Did I? Oh, yeah, good. I'm glad you know. I'm glad you brought that up because I didn't change it here, and I didn't think we were going to make it this far. But yes, 22B and 22C are flipped. They should be the other way around. So this should be 22, and I changed it on one on my computer, but I haven't changed it on the slideshow. Yeah, so it should be 22. Thank you for pointing that out. You guys see that? This is the primary, this is the secondary, and then this is the colored ones are the tertiary. I love it when people pay attention. Yes. All right, and again, like I said, keep in mind that the carina is an internal structure at the bifurcation here, all right, of the trachea. All right, so there's the trachea with the C-shaped cartilage rings here. All right, and then the larynx is up here. That's the thyroid cartilage, the cricoid cartilage right there. What bone is that right there? Hyoid bone. Yep.
So for these, would it be like right and left?
For the primary bronchi, yes. Yes. But for the secondary bronchi, there's tons, because there's different lobes, but yeah.
So would we just say vertical primary bronchus, or would we say right vertical?
You don't even have to say the vertical. You can just say right primary bronchus, left primary bronchus. Correct. Yep, because this is the anterior portion, because you can see this is the front here. And plus now we already know which is which too, because we know the characteristics between the primary and the second, and between the primary left bronchi and the between the right primary bronchus and the left primary bronchus. We know that the right is more vertical, goes down, and that the left is more horizontal, flares out.
But if we happen to put horizontal and vertical on the chest, would you say that it's better?
I wouldn't mark it off, but okay. So as we move further down, now we're going to start to approach that respiratory zone. Okay. So physiologically or functionally, all right, the respiratory zone is very small compared to the conducting zone. Conducting zone includes your oral, nasal cavities, the pharynx, the larynx, the trachea, all the bronchi, until we get down to the respiratory bronchioles. So it's a very small portion when we're talking about the respiratory zone. All right, so basically what we're discussing here when we get to the respiratory zone are going to be the respiratory bronchioles, the final last part of the piping system, all right, our alveoli ducts, which we'll get into, and then at the end of these ducts, we're going to have the sacs of alveoli there, okay? So when you hear people talking about alveoli just in general, they're talking about like those grape-like cluster sacs at the end of the respiratory bronchioles. That's what they're referring to, okay? So keep in mind, all right, when we're looking at this from a functional aspect, all right, our goal in the respiratory zone is to facilitate gas diffusion. All right, and we were learning in chapter 5 about tissues and whatnot, and which type of epithelium is the best type of epithelium to have. Simple by far is the best. You want to have a simple epithelium because it's the thinnest barrier possible. Okay, so when we talk about the epithelium here, all right, and the respiratory bronchioles, all right, and when we get down here into the alveoli, all right, notice how in the respiratory bronchioles we're dealing with just simple cuboidal epithelium. And when we were up there in the conducting zone, we saw pseudostratified ciliated columnar epithelium. That's pretty thick. Well, I shouldn't say it's pretty thick. It's thick in comparison. Okay, so the simple cuboidal is thinner, but then when we get to simple squamous, all right, that's one cell layer thick. All right, and when we talk about, here's the crazy part, when we talk about simple squamous epithelium involving the alveoli and then the capillary, how many cell layers thick is a capillary? Endothelium, how thick is that? It's one cell layer thick. All right, endothelium is simple squamous epithelium. It's one cell layer thick. So when we're dealing with the epithelium between a capillary, all right, and an alveoli, we're dealing with, this is a horrible picture. All right, we're dealing with, all right, simple squamous epithelium in the capillary, and as you know, epithelium sits on a basement membrane. Well, here's the nice thing. We've taken advantage of this. We've got this thin layer of basement membrane that the capillary shares with the alveoli. It's really, so this is virtually the thinnest. The only thing that could make this thinner was if we got rid of the basement membrane. Okay? So it's really thin. And what's its job? Facilitates that gas exchange between carbon dioxide and oxygen. All right? You can't have it getting in the way. All right? That physical obstruction is a problem. So as you can see here now, here's our bronchiole. Okay? We start to get smaller. This is all smooth muscle that's lining. Now we get down here, all right, to the respiratory bronchiole. That's that small pipe here. And then at the end of that, we have just what we call the alveolar duct. And that alveolar duct leads into the actual alveoli, these sacs, right? These balls here. Okay? If you notice, if you look at the alveoli, they have a bed of capillaries that sit right on top. And at one end, all right, you're going to see that we have, all right, deoxygenated blood. All right, it's blue. All right, but guess what? It's the artery, remember, because the pulmonary circulation is taking deoxygenated blood away from the heart and it's bringing it to the into the respiratory system. Okay? So when blood leaves the heart, it leaves through an artery. So the pulmonary arteries are carrying deoxygenated blood to the respiratory system. Okay? So that's what we're looking at here, the pulmonary artery. All right, so it's bringing the deoxygenated blood, and then as it's undergoing that gas exchange across the capillary bed, all right, that blood is now exiting into the pulmonary venule, but that's oxygenated blood. Okay, and that pulmonary venule is then going to dump its blood into the pulmonary veins, which will eventually bring it back to the heart, and it'll dump it into the left atrium. And the left atrium will dump it into the left ventricle and then pump it out to the body. Okay, so this is where we're going to see that gas exchange. So here you can see, all right, on this one here, all right, this model is a little bit different than what I was just showing you. All right, here you can see, here's the terminal bronchiole coming down, all right, and let me just go through, all right. Terminal bronchiole, then we're going to get down to the respiratory bronchiole as it's down here, and it gets cut off here. But that respiratory bronchiole is then going to lead into, which we don't have a picture of here, the alveolar duct, right? And then at the end of the alveolar duct, we'll see the alveolar sac, which is depicted down here. Okay. 23F, that is the pulmonary arteriole. I don't like how they actually have this. Oh, no. Nope, I'm fine with that. All right, deoxygenated blood, don't be fooled. All right, I know we're used to seeing if something's red, it's an artery, and if something's blue, it's a vein. Okay, but in this situation here, all right, remember, we're dealing with deoxygenated blood coming into the respiratory system. Okay, so if it's blue in the respiratory system, we're going to see that this is deoxygenated, so this is going to be an artery or an arteriole. Okay, and if it's red here, all right, that's going to be a venule. And you can see the capillary bed down in here. That actually is a good place to stop, because we get into the, when I say the fun stuff, the interesting stuff. So I'll leave that up there and let you folks copy it down there. Any questions about that? Okay. I noticed that, and this happens every semester, so I'm not going to disparage the larynx, but every time I get in talking about the larynx, I can see people's eyes just glaze over. For whatever reason, some people are just not interested in the voice box. So I get it. I get it. Any questions for you folks at home? All right. If not, I promise you I will get those tests finished is a top priority of mine. Believe you